Today, we will be talking universal health coverage. Universal health coverage simply means that an individual or a community is able to access quality health care without suffering financial hardship. With this in mind, the National Health Insurance Scheme, NHIS, was floated in 1962, but it was eventually launched in 2005 under the former Minister of Health, Professor Qhite Ewelike, a health economist like our guest for today. Unfortunately, 16 years later, the insurance coverage is still below 5%, and the majority of this percentage is from the formal sector. In other words, over 80% of Nigerians still have to pay from their pockets for health expenditures. Bear in mind that the minimum wage in Nigeria is 30,000 monthly. TradingEconomist.com says that the average living wage of a Nigerian is 42,500 naira. Now do the mathematics. The answer you get is the reason a majority of Nigerians are just one major disease away from poverty. Our guest today is Dr. Uchenna Ewelike, a senior public health physician and health economist with several years of experience in developing health systems. We'll be discussing on the impact of the low UHC on patient care, clinical practice, and Nigeria's health system. My name is Ekwe Onyekwele. This is the Qhite Coat Report. Thank you for joining the conversation. You're very much welcome, sir.
Thank you, Ekwe, for having me.
Like I mentioned earlier, the coverage has been less than 5% after over 16 years. What do you think is responsible for that? The factors responsible for the slow pace of enrollment?
Well, Nigeria has had a relatively not fair coverage in terms of one of the indicators we use in tracking universal health coverage. When there are a lot of factors that may be contributing to that, because the concept of health insurance is not a free concept. Somebody has to pay for health services that is being utilized and consumed. And if somebody has to pay for it, it has to be funded and all that. So those are the things that makes the contribution to population coverage low. But in the course of these conversations, we will also look at other contributors to population coverage and how it relates to Nigeria. We haven't done much in terms of coverage. We expected that we would have leapfrogged from a single-digit coverage from now, but then it is work in progress. There are other things that has commenced in the recent time, which in the course of these discussions I will unveil, which may put together will set a trajectory for universal health coverage in Nigeria.
So when we're talking about the factors really responsible for this low enrollment, would you say political will, lack of awareness, illiteracy? What would you say?
Number one factor that affects coverage is the financing. As I said earlier, service delivery is expensive and it has to be paid for. So when you have a sustainable financing system that ensures that resources are put, enough resources are put for population coverage, the population will be covered.
Who currently pays for insurance in Nigeria, health insurance? Is it the government or is it part contribution, individual government?
There are different models.
Yeah.
There are different models. In Nigeria, we do a mix of the beverage and the Bismarck model. What that means is that we do some form of tax-based financing and also some form of payroll deduction financing for those in the organized private sector and the formal sector. But then, the government contribution most times constitute what we look at the other tax-based financing that supports financing the health sector. But then, if we want to have a leapfrog in terms of total population coverage, we must put into consideration the fund availability for that population coverage. So currently, those in the formal sector are having payroll deductions.
That's those in the private sector, the formal.
Yeah, there is organized private sector.
Yes, the organized
Those
private
organized
sector.
private sector have payroll deductions, which is a contribution from both the employer and the employee. Is also the same for those in the formal sector.
Yeah. I read somewhere that civil servants don't pay for insurance; they are not being deducted or charged for. Insurance.
when the president Olusegun Obasanjo did the launch of the health insurance in Nigeria in 2005, there was supposed to be an agreement that the employer pays 10% and the employee pays 5%. But currently, what is being utilized is the contribution from the employer. And I think there is still negotiations and agreements and discussions with the management of the insurance agency in Nigeria with labor. Is work in progress, and I'm sure they will have them to key in, because evidences abound that health insurance is contributing to financing health maximally in Nigeria.
When we want to cover the informal sector, bearing in mind that it's made up of mostly the poor, is it going to be, what model of UHC are we going to use for them? Is it going to be part contribution, or is the government going to fully fund that sector?
We have a very large informal sector in Nigeria. And large informalization is a difficult thing when it comes to resource mobilization to finance health, because you do not have the mechanism to do payroll deduction. And most of the people in the informal sector, because of the large level of informalization, will find the government also find it difficult to get their own contribution in terms of tax and their contribution into the government coffers. So if you have such a population, and looking at our GDP level and our economic status, for us to have an effective, equitable, and efficient financing of the informal sector, government has to do the bulk of the contribution for those in the informal sector.
Okay.
In that way, those that are able to contribute will contribute, but those that are not able to contribute in terms of their socioeconomic status, we have an equity contribution coming from government to take care of their own population coverage. Okay.
In your opinion, when do you think Nigeria will be able to achieve full universal health coverage?
Well, UHC is a journey, and it takes a gradual process, and it's also its journey is dependent on the country's level of development, and also the country's level of political will in terms of the drive towards universal health coverage. But the good thing is that the good news that is coming in is that the country has shown some commitment in the recent time in terms of improving financing the health sector. In 2014, during the time of President Goodluck Jonathan, the National Health Act was signed into law. And that is the first health act that has a holistic view of how a health system should run. And luckily for us also, in that National Health Act, Section 11 of that National Health Act makes provision for an earmarked funding called the Basic Healthcare Provision Fund. And luckily for us, the current administration has commenced the release of that fund, which is currently being used in the implementation of the Basic Healthcare Provision Fund. I can comfortably tell you that more enrollment is coming on board, and it is now targeting the vulnerable population and the people that are expected equitably to benefit from this fund. So in terms of population coverage, we are increasing the number of population coverage, and we're also targeting the expected population that requires that fund.
Yeah. Do you think
I can't give a definite date that we are going to achieve UHC because it's a journey.
Okay, give me an estimation.
It's also a gradual process.
10 to 15 years.
I think as more funding comes into the health sector, more absorptive capacity is demonstrated, and also more increase in terms of budgetary allocation to the health sector, also more increase in terms of what we have also from basic healthcare provision fund, equity funds from the state, we are likely going to achieve universal health coverage within the shortest possible time.
Okay.
When we track what we've done so far, we haven't done much, but there are a lot of work in progress that could help us to increase total population coverage. We are still at single-digit coverage, which is not good for a country like ours with huge population. So if we can leapfrog from single-digit coverage to double-digit coverage, that will be wonderful.
That will be wonderful.
Next thing we'll take into consideration is financing health. You are aware of the Abuja Declaration of 2001 that requires that governments, people in African Union should make at least 15% budgetary contribution into the health sector.
Yes.
That hasn't been done. If you take a track retrospectively over years, you see that we are still at neighborhood of 4.5 to 5.5. That hasn't been achieved.
Okay.
Yeah, but the most important one, which depicts what happens in the health sector, is what we consider the out-of-pocket expenditure, which is one of the trackers that WHO developed. The danger of out-of-pocket expenditure is that it puts families into catastrophic expenditure and impoverishing expenditure. So families bear the brunt of household expenditure in terms of their health, and that drags them into the vicious cycle of poverty, disease, and sometimes death. Our out-of-pocket expenditure currently, using a validated national health account, is about 76.6%. So what this means is that the people are bearing the brunt of the cost sharing in terms of financing health. And this is a very regressive way of financing health. It's inequitable and it is inimical to the drive towards universal health coverage. So our plan is to drop it to the WHO recommendation of less than 30% out-of-pocket expenditure. Because
with state insurance scheme, do you think that will also fasten?
The decentralization of health insurance in 2015 is one of the best things that has happened to the Nigerian health system. It has demonstrated the evidence now that a unitary polling system is not possible in Nigeria, but a decentralized polling system, what we call an integrated polling system, is the best option for a federation like Nigeria. So evidences abound in many states, in Anambra, in Bauchi, in Kano, in Delta, in Osun, in Oyo, in Ebonyi, and all that. So the health insurance systems are quite very efficient now, and it has demonstrated that evidence that what we just need to do is to continue the decentralization and ensure that at the state level, that's at the regional level, more funds also enter into the pool from the equity fund that the state governments are supposed to contribute. So if we do that, the population coverage will increase dramatically.
Is there any African country with full UHC?
Yeah, Rwanda has done very well in terms of universal health coverage.
Wow.
And what happened in Rwanda was a rejig of the law in Rwanda that made contribution to health insurance very compulsory. And what they call it is the CBHI, community-based health insurance. But that is a label. What happens in Rwanda is that there is almost a compulsory contribution to health insurance. And the equity contribution from government is also very sustainable and is steady as regards to funding into the health sector. And so that has made Rwanda a central point of discussion in African countries in terms of universal health coverage.
Do you think Nigeria can successfully fund the health system with just health insurance?
Health insurance is not
generating a sort of revolving fund that can smoothly or to an extent efficiently run the health system.
The current health system in the UK,
NHIS.
The NHIS is self-sustaining. And not just that it is serving the health need of the people of the UK is also a pivotal point in terms of economic growth and development, because NHS is one of the largest employer of labor in the UK. So I can now answer that question in the affirmative.
Okay.
That if we have a sustainable financing mechanism in Nigeria, built on quality and there is confidence in the system, also direct investments, foreign direct investments into the health sector, Nigeria can comfortably finance its health system. All we need to do is to do the right thing and get the right persons to drive the right system. And we will be able to finance the health system.
Okay. There's a question I want to take you back to earlier on when we were talking about the components of UHC. You mentioned absorption capacity. So funds is still just not enough. So can you just elaborate on what you mean by absorption capacity?
Yeah, people think that giving more money into the health sector is the only way to solve the problem of the health sector. I completely not agree, because we don't just talk about more money for health, we also talk about more health for money. We want 15% budgetary allocation to health.
Okay.
Assuming at the state and at the national level, you're able to get 7%. And such money is also disbursed to you, because sometimes there are much differences and disparities between estimates and actual. Estimates are what is expected in terms of budgetary provisions, and actuals are what is actually disbursed. But if your actuals are up to the level that is being budgeted for you, you must efficiently demonstrate that there is a need for those services. So what you need to do, so that is the duty of us in the health sector, to make sure that both sides of the financing are optimal. The first is to do what we call the supply side readiness. The supply side readiness is getting the facility ready, getting the equipment ready, human resource for health, and an optimal environment for delivery of health services. When this is done, then you can now fit it in with the demand side financing. And that is where the insurance comes in. So what the demand side financing does is to ensure that the sustainability of the financing is optimal.
So do you think Nigeria has that absorptive capacity that we're talking about presently?
We are doing well, we are trying, but we should demonstrate more in terms of absorptive capacity. We should be able to demonstrate to also the ministries of finance and budgets, national planning, and also at the state level, that the health sector has the capacity to utilize this fund that we ask for. We have also demonstrated some level of absorptive capacity, because the basic healthcare provision fund that has been released by government has been disbursed, enrollment has commenced, and I'm sure if more disbursements are done, more people will be covered.
But that's not just the only factor you mentioned. Human resources, and we have the migration of health workers out of Nigeria, facilities, and we know some health workers can't even find employment. So, and then our hospitals, in terms of equipment, we know reports say that the situation is currently abysmal. So are we really capable of that absorptive capacity you're talking about?
You see, there are a lot of factors that are driving the exodus of health workers, and also people in quote and thinking that the quality of services we render is not optimal. We need to begin to think about what we call the reversal of inverted pyramid spending we have in Nigeria. And that reversal of inverted pyramid spending is to ensure that we have more services rendered at primary level of care. Because it is not most cases that needs to move from primary level of care to secondary and sometimes to tertiary. So if we can systematically improve our primary level of care and improve secondary level of care, less cases will go to the tertiary level of care. And if the funding is also improved at the primary level of care, it means that the system becomes efficient. And the drivers of the system will also improve on innovative ideas on running the system. And you will have more likelihood of people being retained. Because when a doctor is sure of his remuneration, he's sure of the environment, he's sure of his safety, and when comparatively he looks at what he gets compared to his colleagues abroad, and when there's no more disparity, he's likely to stay. And I'm confident that if we have an improve in our financing and also more political will in terms of commitment for the disbursement of this approved service funding to the health sector, we will retain most of our health workers and service delivery will improve.
Okay.
And when service delivery improves, more people will have confidence to also come outside of this country to come and utilize health services.
So do you think the introduction of a state health insurance scheme will strengthen the primary health care?
Definitely. In fact, part of the ways of implementing the basic healthcare provision fund is through the states. And that has also made many states to improve in terms of legislation and legal backing for state health insurance agencies. It's definitely going to improve the primary health. And when you look at the objectives of the basic healthcare provision fund, you see that strengthening the primary health system is part of the key objectives of the basic healthcare provision fund.
That's wonderful. Thank you so much for your time. And I wish you all the best.
Thank you also for having me. And also, I want you to sustain the discussions on universal health coverage.
We'll definitely do that, sir.
That's the real way to go now.
Yes, sir. We'll definitely do that. All right. Thank you so much for being with us till the end of the show. This is still the Qhite Coat Report. Bye.